Imagine this. You're in the OR for a scheduled cesarean section. Your patient is a healthy 32-year-old G2P1. She receives a spinal anesthetic, the block sets up quickly, and the surgery begins uneventfully. A few minutes after delivery, she looks at you and she says, "I feel like I can't breathe." Her blood pressure starts dropping, her voice sounds weaker, and she seems increasingly anxious. As the anesthesia provider, you have to decide very quickly. Is this anxiety, normal chest heaviness from a spinal, or the beginning of a high spinal? That's the focus of today's lesson, recognizing and managing a high spinal after neuraxial anesthesia in the obstetric patient. By the end of this short lesson, you should be able to identify early clinical signs of high spinal anesthesia and describe the immediate management priorities. We're going to use one brief patient story, then I will pause twice and ask you to predict what is going to happen and what you would do next. High spinal anesthesia is uncommon, but when it occurs, it can progress rapidly. In obstetric anesthesia, this matters because physiologic reserve may change quickly, and we are responsible for both maternal and fetal well-being. The key point is that high spinal is not just a high numb level, it's a clinical syndrome involving excessive cephalad spread of neuraxial anesthesia, which can affect sympathetic tone, respiratory mechanics, upper extremity function, and eventually consciousness. Let's return to this patient. The baby has just been delivered, the uterus is exteriorized, the patient says, "I feel like I can't breathe." You check the monitors, blood pressure is 78/42, heart rate is 52, oxygen saturation is still 99%, and end-tidal CO2 is not available because she's breathing spontaneously with a nasal cannula. You ask her to squeeze your hands. Her grip is weaker than it was a few minutes ago. She's able to speak, but her voice is faint. She denies pain, but she feels very heavy in the chest. Here's the first small teaching question. What findings in this story make you concerned for a high spinal? The concerning findings are hypotension, bradycardia, subjective dyspnea, weak voice, and upper extremity weakness. One teaching point I can emphasize with SRNAs is this. Oxygen saturation can look normal early. A patient may say, "I can't breathe," before the pulse oximeter shows a problem. That complaint should not be dismissed as anxiety until you assess the block level, respiratory effort, hand grip, voice strength, blood pressure, heart rate, and mental status. The early signs of a high spinal may include nausea, hypotension, bradycardia, difficulty breathing, difficulty speaking, upper extremity numbness or weakness, and anxiety. As it progresses, you may see altered mental status, apnea, and/or loss of consciousness. So the first major point is high spinal is recognized clinically, and early recognition depends on listening to the patient and reassessing more than just the monitor. Now let's continue the case. The patient's blood pressure is now 70/38. Her heart rate is 48. She's still awake, but she says it's harder to take a breath. The obstetrician says, "Are we okay?" Second question, what are your first 3 management priorities? Think in terms of circulation, oxygenation, and preparation for airway support. The immediate priorities are to call for help, support circulation, and support ventilation. First, call for help early. This is not a situation to manage quietly by yourself. Let the surgical team know what's happening, ask for assistance, and prepare for possible conversion to general anesthesia. Second, treat the sympathectomy. Increase left uterine displacement if appropriate, give a fluid bolus if indicated, and administer vasopressors. Phenylephrine or ephedrine may be used depending on the heart rate and clinical context. If severe bradycardia is present, atropine or epinephrine may be needed. Third, support oxygenation and ventilation. Apply supplemental oxygen, assess respiratory effort, and be ready to assist ventilation. If the patient becomes unable to ventilate or loses consciousness, proceed with airway management and intubation. A simpler way to remember this is recognize, resuscitate, and be ready to secure the airway. Recognize the symptoms, resuscitate the circulation, be ready to ventilate and intubate if needed. In our case, you call for help, increase oxygen, treat the hypotension and bradycardia, and prepare airway equipment. You continue talking to the patient so you can assess her voice, mental status, and ability to respond. Her blood pressure improves after vasopressor treatment, and her symptoms stabilize without needing intubation. The reason this case is important is that the outcome depends on early recognition. If we wait until the patient is apneic or unconscious, we have missed the earlier warning signs. To summarize, HighSpinal anesthesia after neuraxial blockade is a clinical diagnosis that can involve quickly. The warning signs include hypotension, bradycardia, dyspnea, weak voice, upper extremity weakness, and changes in mental status. The management priorities are to call for help, support circulation with vasopressors and positioning, provide oxygen, and prepare for assisted ventilation or intubation if needed. The take-home message is this: when an obstetric patient with a spinal says, "I can't breathe," pause, assess, and act early. Do not rely on the pulse oximeter. Before we end, ask yourself, in your next cesarean section, what signs would make you stop and reassess the block level immediately? Any questions?